thirst is an important mechanism. It is caused by an increase in the serum osmolality, which is the main driving force, and requires only a 2 to 3% increase in osmolality, which can stimulate the osmoreceptors at the anterior hypothalamus. Reduced blood pressure or is another important factor, which requires a decrease of 10 to 15%, which can stimulate your thirst, and angiotensin II stimulates the subformical organ. The secretion of AB8 is triggered by an increase in the serum osmolality and a reduction in the blood pressure. And this acts on the V2 receptor in the collecting ducts from the nephron and increases the permeability to water and urine. Both renin and aldosterone again play an important mechanism, and they are stimulated by increased sodium delivery to the macula densa, or the aldosterone introduces the sodium chloride excretion by stimulating its absorption. If you classify hyponatremia, which we can do by various ways that we can classify hyponatremia, the patient can be asymptomatic or he can be symptomatic. If he's symptomatic, it's because moderately severe, leading to nausea and vomiting, confusion and headache. And if it's a severe form of hyponatremia, these patients usually have vomitings, cardiorespiratory distress, they have seizures, and the Glasgow Coma scale, it can be 8 or below. It can be based on the serum sodium levels. You can have mild hyponatremia where the serum sodium ranges between 130 to 135. A moderate, where between the concentration of sodium is between 125 and 129. And profound in the severe form is where the serum sodium concentration is less than 125 millimoles per liter. It can also be based on the time of development. If it is acute, which is documented to exist in less than 48 hours, it's called acute. And if it occurs for at least 48 hours, it's in existence for more than 48 hours, it's chronic. It can be based on serum osmolality. The hypertonic hyponatremia is where your serum osmolality is less than 275. Isotonic is between 275 and 295. And hypertonic hyponatremia is where your serum osmolality is in excess of 295 millimoles per liter. But the most important way to classify is based on volume status, and I'll spend a few minutes on that. You have to assess the volume status of your patient, whether he is hypovolemic, or hypervolemic. Now, if it is hypervolemic, it's because of the reduction of total body water and a greater reduction of the total body sodium. You look at the urinary sodium concentration, so the urinary sodium is in excess of 20, then it's possibly because of renal losses caused by excessive use of diuretics, mineralocorticoid deficiency, salt-losing deficiency, bicarbonaturia, ketonuria, and one important is the cerebral salt wasting syndrome that we can see in some patients with neurological diseases. If the urine sodium is less than 20 and the patient is hypovolemic, it is caused by extrarenal losses such as vomiting, diarrhea, third space fluids, burns, pancreatitis, trauma, etc. Then we come to euvolemia, where the total body water may be increased, but the total body sodium is more or less the same. And if the urine sodium is in excess of 20, then this is usually caused by glucagon deficiency, hypothyroidism, stress, and one important cause is the syndrome of inappropriate antidiuretic hormone. If it is produced because of hypervolemia, where the total body water is significantly increased and also the total body sodium is also increased, again you look at the urine sodium levels, if it's in excess of 20 or less than 20. If it is in excess of 20 millimoles, then it is usually caused by acute or chronic renal failure. And if it is less than 20, then this can be produced by nephrotic syndrome, cirrhosis, or cardiac failure. Now there is some important manifestations that occur because of hyponatremia of the brain. And it's if your hyponatremia develops acutely, where there is the osmolality drops very sharply or very abruptly from 290 to 220, it can lead to cerebral swelling and cerebral edema. This would not be seen